Start. Okay, we're live. Okay, welcome everyone to Devon CCG Governing Body public meeting. I know we do have at least a couple of people tuning in with us. One of you has provided us with a question. So Paul Walker, if you are watching, we will be answering your question. I'm going to postpone that till after 10 o'clock because one of our executive colleagues will be able to help us answer that, so you get the information that you need. Just a reminder for everyone, because it is a live meeting, please be aware of that. Any discussions or debates we have, if we can have them verbally rather than within the meeting chat, and we just use the chat as a space for us to draw attention. If I haven't seen you raise your hand, then that will be helpful, so that actually all of our discussion and debate happens within that the public arena. As always, what we like to do is we like to start our meetings actually with a really focus on the people who we are doing this for, whether that be our patients or members of the public, or indeed in this time, whether it be those people who are giving so much of their time and their resources actually delivering the care that we commission. So actually, I'm really pleased that Janine and Andreas are here to join us. I caught up with both of you a couple of days ago, and it was really nice to chat through what you're doing, because both of you have been stalwarts in the vaccination programme. So before we do anything formal in the meeting, let's start off by focusing on that. And Janine, are you kicking off for us? Yeah. So welcome both of you to the governing body. We're a sea of people. I won't necessarily go through introductions, but if anyone has any comments or questions afterwards, I'll ask them to introduce themselves at that stage. But we're looking forward to hearing from you about the work that you've been involved in. Thank you.
Thank you. Good morning, everybody. My name is Janine Law. So I'm part-time PCN Ops Manager for North Devon Coastal. So I cover Ilfracombe, Barnstable, Ilfracombe, Linton, South Molton and Braunton GP practices. So we set up the Barnstable Mass COVID Vaccination Centre. So I was part of the initial small group that set that up. I actually joined the PCN in July last year on a year's contract. And I'm actually from not from primary care at all, so I'm from a business background, hospitality management. So perhaps my view on how we work is different, and this has found really helped us with the volunteers. So we found that we were really struggling with staffing the clinic after we did the first one or two, obviously because practices have really been pushed with COVID. A lot of the staff were shielding or weren't working. So we decided then we obviously had to do to really use our resources with the volunteers that kept coming forward. To
enable that to happen. So our teams are working through that. But then kind of parking the robotic, which is about now 17.
Right. Sorry. Okay. Sorry.
Carry on. I think someone wasn't on mute, but I've just muted them, so we should.
Okay. Right. Okay. So I was working full time. I managed the clinics as well as actually organising the clinic initially, and do PCN work. And then I decided there were so many volunteers across the 3 PCNs. So we work with Barnstable and Torridge PCN as well. So there's 14 GP practices altogether. We were having loads of volunteers coming forward. And there was nobody to organise them. So me and my wisdom volunteered. It's been a huge sort of undertaking, but I'm a people person, so I sort of naturally sort of got into it. So currently we have 139 volunteers. What I've actually done is put them onto a free app, which is an employment scheduling app, which we actually use in hospitality and sort of in restaurants and things like that. So I loaded all these people onto an app Took them a long time, lots of hours, and it's great. So now actually I've got 139 people on the app. What we do is load the shifts onto the app, publish them, and people pick and choose the shifts they want. They're all 5.5-hour shifts, so morning or an afternoon. Works most of the time great until people pick the wrong shifts or they need to trade or something. So it takes some management still, but hugely much time reducing by managing it on the app. So I set all my volunteers up. I gave them put a volunteer pack together, so they were covered for their insurance, their indemnity, data protection. They don't actually see any patients' records. Obviously, they do the meet and greet. They help me do the queue management. We have trained people in the observation area, so retired medics, clinical staff, if we're doing Pfizer clinics. So we do the obs, and then we have staff volunteers helping them leave the clinic and in the car park as well. It's taken hours to do, but it is great now and it works really well, and my volunteers are amazing. I am so proud of them. We have a fabulous team. We have great support from them, the staff, you know, really recognizing what they're doing. And we're lost if we found if the car park isn't managed right, the clinic is a nightmare to run. So and the clinic door is a big role, so that we found was really important. They've got their own high vis jackets, their own badges, which they're so proud of, which is fab. And then what I've also done is helped to help me. Andres, who's going to chat in a minute, is one of our volunteers. He mistakenly offered to help me with organising the volunteers, and he hasn't escaped since. He does it all out of his own time. He actually volunteers at the clinic as well as helping me sort of manage this app that we have. So to date, we have around 18 volunteers per shift. So there's an AM and a PM shift. So we have like 36 volunteers in a day. The clinics to date, we've done 46 clinics, including this week. And that's not including individual PCN clinics. So I've actually reworked my figures out, Paul, and what we've actually saved to date, going against minimum wage costs, if we were paying them, which we're not, is £81,000 in staffing fees. Besides, you know, the financial side of it is the releasing the staff back to practice as well. So it's great. We're coming up to doing the end of our second doses at Barnstable. That's now going to be taken over by the North Devon Hospital, and I've been I've been asked to assist in their volunteers as well, to continue the volunteers that are there and add the hospital volunteers into that and actually set the app up for them as well. So it's great. Challenging, but I really think coming from a sort of business management, hospitality management background has really helped in organising the volunteers. And I think, as I said initially, I think it gives me a different approach to the way that you work things in primary care, very different. Yeah, so that's where I am at the moment. I also, as I said, manage the clinic, so I'm there tomorrow and have a meet up with all my people, which are lovely. The staff, the volunteers, I always think of them as mine. So yeah, they're brilliant, and hopefully Andres can give you a different perspective than on his view. Hopefully it sort of corresponds with mine and it's a positive. But yeah, happy to take any questions or help in any way that I can. Thank you, Paul.
Great. Well, let's hear from Andres, and then we'll have a few questions.
Okay.
Yes, that'd be great. Andres.
Yeah, hi everybody. Janine, I'll do my best not to let you down. Make sure my comments are commensurate with yours. So yeah, I work full time in recruitment. My friend who had, so as I believe it happened at the very beginning of the vaccination process, at the beginning of January, it was very quick fire. Am I correct in saying, Janine, that it was just Roundtable that were helping then?
Yeah. We had about 6 people, I think, and that was about it. until you came on board.
And then, yeah, so it was round table, and I used to be on Ilfracombe round table, and I got a phone call one day saying, Andres, you know loads of people, can you come and do a shift in the car park and help us out? So I did, and I could see it was very short staffed. Being in recruitment, I know about staffing and putting people in places. I could see it was short staffed, and everyone at this point, obviously it had been very quickly thrown together. So I set about trying to get some more people on board with Janine's help. My wife luckily is the president of Ilfracombe WI, so we could grab some of those guys. I managed to grab quite a few Freemasons, local Freemasons, more round table, and we had some more lions and things, and then just some civilians that happened to be married to someone on round table or Rotary that said, oh, we can help as well. And it kind of grew exponentially from that, and people volunteered. And as they did up at this point, I guess Janine was adding them to the list. I done a number of shifts on a Saturday because that's all I could do, full day shifts, and I didn't know Janine, but I'd seen her walking backwards and forwards looking particularly harangued, and so stupidly said, you don't know me, however I know the implications of managing all these people. Do you need a hand? And here I am 4 months later. I'm only 18 and look at the state of me. So principally what I've done, I still volunteer. However, that's because work's got busier and busier. That's become less and less. And what I do now is I add all of the shifts on. So Janine will say, right, we've got 3 clinics this week, 2 Pfizer and 1 AstraZeneca, or it's a mixed one, and we've got 6 ranks or columns. Can you set up all of the positions commensurate with that? So I'll do that. The phone, bless it, once I've set them all up on the laptop, all of the schedules and all of the shifts, I send a message out to, we've got a Facebook group, so I'll send a message out to that saying, be aware guys, we've got shifts coming on Wednesday, Thursday, Friday of next week. We'd be very grateful for your help. Genuinely, within a minute of me pressing go, I've usually got 40 or 50 shifts filled within a minute, and my phone's going mental and draining the battery while I'm trying to accept all of these and put people in the correct places. That poses its own challenges because obviously you've got a wide range of abilities technology-wise. A few guys in their 20s, some who are sept and octogenarians that struggle a bit and end up putting themselves in clinical positions when they shouldn't. And then I spend the rest of the evening trying to move people around so they can carry on doing the roles. That in a nutshell is what I've been doing. The challenges with that are maintaining a core d'esprit, because when you have that many people from that many backgrounds, and they are from varying backgrounds, from chartered accountants to window cleaners, things are going to grate eventually, and you get people calling you saying, I'm never working with this person again. And as I said, I believe to Paul the other day, it's very much like organising a wedding seating arrangement where Auntie Joan can't sit next to cousin Kevin because they had an argument in '73. And so there's not a lot of that, but there is a certain amount of being a social worker involved as well. For the most part, there is, as I said, a real core d'esprit. People are turning up and driving 15, 20 miles sometimes to come and volunteer. Certainly I live in Ilfracombe, that's a 15-mile drive, and there are a lot from there. So they'll go in, they'll do quite often a long shift, so a full 11 hours, because if they're driving that far, they may as well stay for the whole thing. Usually fueled by goodwill and cakes and buns that have been donated by a local business. And that pretty much is what I do in a nutshell.
Brilliant. Thank you both. If you've got any questions or comments, please raise your hands. Can I just say thank you? I was trying to get the absolute numbers for Barnstaple, and Darren may be on who'll be able to give us the numbers. But actually, you know, if you look at all the over 50 and above, and we're in the region of 90% of those people having had at least their first vaccine, and it just shows the throughput that you've had and the success that the vaccination program has had. And you know, it's Andreas and it's Janine, it's people like you who are putting in, you know, exceptional hours and coordinating what sounds really complex. So thank you very much. It brought me back to sort of you sent a shiver down my spine as I thought about when we tried to arrange our wedding tables. We opted for a buffet and people could sit where they wanted. That was our solution. But I suppose you can't just have people turn up when they feel like it. You have to be a little bit more organised and manage some of those difficulties. Can I just ask you, Andres, before we bring other questions in, certainly, you know, I saw some people arriving, particularly in the over 80s, who hadn't been out the house for months, who were really quite nervous. I saw some amazing people who were volunteering, do some, you know, and any people you met where actually it was, you know, it was almost like you were the first person they came into contact with, and so the onus was very much on you to get them ready for what they were going to go through to get the vaccine. Yeah,
absolutely. It's a good point, and I meant to mention that actually. So it became abundantly clear pretty quickly. With the first guys that turned up in early January, they were dolled up because it was the first time a lot of them had gone out. It was almost a trip to Butlins. These guys hadn't been out for 6 or 7 months, and they'd perhaps only seen a carer or one family member, and they were all done up in their tweeds, and they were stood out in the queue an hour before, and we had to kindly, because it was January and raining sideways, escort them back to their cars and say, please don't come out. And that was a challenge. But what we found was quite a decent percentage of these guys, if they were coming with a carer and things, they perhaps had only really had contact with that carer since March, April of last year. And then they get to myself, who then at least was always on the front door. What would happen? They'd come down to me looking quite nervous, quite frail, because a lot of them hadn't done much walking in that time because they've been confined to quarters. Get to me, and there's literally a 3 meter walk down a corridor where they'd be confronted by another person to squirt gel in their hands, and then they'd be unleashed upon the unsuspecting vaccinators. But also there'd be potentially another 100, 120 people in the room as well. They hadn't seen this. And it didn't take long for us to realise actually these guys aren't psychologically equipped for it anymore. And so there was prep, and that fed up the line. So we had the conversation with myself, and then I talked to the person at the top of the ramp, and then all of the car park guys, and everyone's been great. And so if you could see someone coming into the car park that was just with a carer, they'd have a little bit of chat with them before, and they'd be prepped all the way down. So by the time they got to me, I could say, just be aware, as you're walking through, as you see the lady there, when you turn around the corner, there will be other people having their vaccines. They're in exactly the same position as you. Please don't worry. You'll be socially distanced, and you'll be guided through every step. And we've always managed to have enough volunteers that they were never by themselves for more than probably 5 or 6 steps until they're escorted out the other end of the centre. But yeah, that was very important, and was abundantly apparent early on.
So it's not just what you've done in your role in volunteering, it's how you've gone about it has made such a massive difference. So thank you. They're queuing up now to ask questions. So Judy.
Thank you so much. And I mean, what you've done is amazing, and what your colleague volunteers have done. And your presentation was great. May I ask one more thing of you? I think that an awful lot of people I know, since I stopped full-time work, I have really enjoyed where I have volunteered. And I wonder if you could get a few volunteers to share with us what the volunteer experience gives them, because there may be ways in which we could use volunteers that gives an opportunity to the volunteer and to patients in future, not just around vaccination, but around other things. So what makes it a good experience for the volunteer, and what is the training that they have most valued? So learning from your 139 people, so that we can consider how best to develop our volunteering policies in future. So I'm not putting you on the spot to answer now, but I am asking you if that might be a possibility to do for us.
Absolutely, I can get amongst the troops and certainly ask the questions.
Yeah, I think looking at that, I mean, Andre will back this up. In Ilfracombe, we've actually got a great community. That's where I'm actually from, and that's actually where we've pulled a lot of the volunteers from, because they actually set up real individual community-based support for a lot of the vulnerable people during the lockdown in COVID. So that's where a lot of the round table a lot of the Rotary. We're actually already supporting people in the community, and we've actually sort of pulled further on their volunteer experience and expertise at the clinic. So I think it is already happening. I think a lot of people have felt very empowered, you know, to help other people, and really to have brought a community spirit back, certainly to Ilfracombe. And I think if we can use that and draw on it, as you quite rightly say, and move forward and not lose all this knowledge that we have, and empower people to help again in the community, it can only be really positive.
Yeah, I think so. Anecdotally, we had one lady who's only just finished with us because she's had to go back to work, and she did pretty much every morning shift since we started, Louise. Really, really great. And I spoke with her afterwards, and she's only in her 40s. You know, she's a mum, got children and a husband and everything else, but she got furloughed because of the kind of job that she did in March last year, and she'd had very little, and she found it as much as anything, and she was great, you know, really instrumental in helping out with everything. So she wasn't just a buckshy, for want of a better expression, volunteer. You know, she really put her all into it. But I think it became, and for a lot of people, almost a support network as well. So it was reciprocal. You can't odds that. You don't know that's going to happen. But Janine's right. Ilfracombe and surrounding area, we do have, because we have Freemasons. Well, a lot of places have that, but Freemasons and WI and Roundtable, and they do organise a lot of charity events. We almost had a turnkey solution that still needed managing, but we could all transplant there, which I would imagine, having lived all around the country, certainly the larger communities and cities, you'll perhaps struggle with a bit more.
Darren, I will come back to you, but I'll bring Andrew in now because you got your hand up, but also whether you've had any thoughts about what we can do to capture that volunteer experience and take some learning from it, and what we can do in that space as well.
Yeah, thanks, Paul. Thanks, Janine and Andreas. Good to see you again. I thought the presentation was excellent. Before I come to Paul's point, because I think we do need to do an awful lot more. We've got a post that we've put in place, led by Darren Halifax, to work much more closely with the voluntary sector. And I think, Paul, part of his work will be about capturing the experiences and promoting what volunteers do. But I was just going to ask Janine and Andres about, I think the NHS runs way better with volunteers. We would really struggle at times, I think, without volunteers. I just wondered what your view is about how we could better recognise the role that volunteers play in the sort of services that we run, because it is invaluable, but we probably could do a lot more to recognise their contribution.
Yeah, I think if I start on that, Andreas, I think their contribution is immense, you know, let alone financially, what it saves us regard, you know, that's the sort of sideline of it. It's huge. I think a lot of people have done it just for the goodwill, you know, they want to be part of something. As Andreas has said, it's been a support group. I think, you know, I do think this has shown that we do need volunteers, and that we do need perhaps some kind of organisation where we're actually, you know, what I sort of set up, this little group is great. Everybody messages each other. It's all there. If they have any issues or complaints or they're not well, they message us. So, you know, whether we can build on that and expand it further. I know that we have got sort of central volunteers bases and people in positions, but maybe we need to interconnect all that so that it is a network. You know, as an example, when I used to sort of run hospitality, we were all interconnected and people would swap around. And like Andreas has said, people have come from miles around to help. I don't think it only needs to be secular in a particular town. I think we could share it. So, you know, we've worked with Torridge, with Westwood Ho people, with Barnstable people, with people from Linton, volunteers that have come, you know, way in. So I think maybe, you know, some kind of support group or a network, you know, that we can just build upon, and that it's there for future use in and around the community, as well as at hospital or at primary care level and secondary care. Andreas, have you got anything else you can add to that?
Yeah, I'm gonna politely and controversially disagree. Sorry.
Yeah.
Yeah, sorry. Big scandal. I think so. I come from an army background. I was in the forces for just shy of 10 years, and I think what's made this so effective, and what I think you will lose if you start to give recognition. I may be very wrong. I've never worked in the public sector, albeit the forces, but I think once you start adding in recognition with the NHS, you'll start adding in processes, and it will cease to become the dynamic force, for want of a better word, that it is. We are able to react very quickly. I believe, and again, I hope I don't get anyone in trouble for this, I believe that Janine requested quite a while ago signage for the leisure centre from whichever group, and I'm not sure, which still hasn't arrived, and that was 4 months in the making. Yet one of our guys in our casual conversation said, "Don't worry, I could knock that up for you, that's no problem," and just did it himself. And it's been in the car park, sat proudly ever since. So the cars know which way to go in, which way to go out, and it's just been sorted over a weekend, and he did it in his shed. My fear is that if we start to give recognition, and perhaps, oh, someone's done 100 of these and therefore they get a coin, like perhaps like you did with the blood donations or any of those things, you then start to add in more GDPR regs and more processes, and it, one, can potentially intimidate certain groups, and secondly, just become an amorphous blob and not the dynamic entity that it is at the moment. I'm not saying that is the case. That would be my concern.
Well, Andrew, maybe that's something that Darren can think through as part of his role as well. What's the right balance there, I think. I'm aware of time. Darren and James, I'm going to go to you, and then back to Janine and Andreas for last words on this. I think we could carry on for ages, but unfortunately we have to do business at some point. But Darren first, and then James.
Yeah, thanks, Chair. Thanks, Andreas. Thanks, Janine. So I think for me, it's more of a comment, and it's a really, obviously, as the SRO for the vaccine program, it's just a real thank you, personal, heartfelt, because I think this program would not have been the success it was without the volunteers. And I think the volunteers, we talk about lots of different roles in the vaccine program, but the volunteers are really the face of the program, because actually they are the first people you see when you come into the car park. And actually, they're the last people you see when you leave the vaccine centre, having been vaccinated. And I think, embarrassing, I haven't quite got to the Barnstable one yet, but every site that I've gone to is just the camaraderie, just the whole buzz and motivation around the volunteers really, I think, puts people at ease. People, as I think you said, Andreas, individuals are visiting these vaccine centres probably the first time they've been anywhere in potentially 12 months, and they're coming into a big environment, lots of people, the clinical environment, the noise and the buzz, and it just, I think we just underestimate actually, without the volunteers, this program would not have been the success it is. And I think just from a Janine's perspective, the leisure centre in Barnstable is one of our three biggest primary care sites. It served our most remote area, so in reality it covered the biggest geographical area, and you've achieved over 94% of the entire population of North Devon have been vaccinated, which is just remarkable, bearing in mind, as you've already said, Janine, this is Ilfracombe, Linton, Barnstable, South Molton. People were travelling from all parts of North Devon. So it's just really just a real thank you, but also recognise that this has been one of our biggest success, I think, in terms of the leisure centre. And that's down in no small part to yourselves.
Thank you.
James.
Yeah, thank you, Paul, and thank you, Janine and Andreas. Hugely encouraging to hear how volunteers have made such a difference across the communities. And I just wonder, given that mass vaccinations are likely to be a part of our everyday life going forward, I'm wondering how we can mobilise this sort of year upon year, the volunteers, but also how we can build upon this as an opportunity to promote volunteering in general, so that volunteering becomes seen as, I don't know, a kind of socially responsible thing to do, which it is, but build upon the success of this volunteering programme so that it filters out into other areas of the community.
Thanks, James. I think that builds on Julie's point that she first made, and actually that's something that it'll be good to hear what Andrew, what you and the team can do with that. Janine and Andreas, I think James is saying, are you up for another 5 years of this? No, not at all. But I think there is a challenge there about how we take the best of this that we've been through with COVID and with the COVID vaccine, and that learning, and that's definitely something I think we should work to try and learn from. Andreas and Janine, thank you ever so much. Any last comments or thoughts you want to leave us with?
No, I'm really proud of what we've done, what we've achieved as a team. Really proud of my volunteers. Just onward and upward. They're excited for the next stage now.
Sorry, let's just try. If you are not speaking, if you could just make sure you're on mute, please, that'd be really helpful. Sorry, carry on, Janine.
Sorry, I just said that I was just really proud of everybody and my volunteers, and they're amazing. I'm leaving my role in July, so I'm hoping that we can now work to hand this out to carry it on. I am with the hospital anyway, so no, just thank you, and thank you for the recognition. They really deserve it. They really do.
Yeah, and from my point, just thank you for your time. It's been interesting to accumulate everything that we've done over that time and try and justify it in my mind as much as anything else. Hopefully that'll mean that I can process it and come up with some better ideas for next week, because we've got a busy week. But yeah, thank you very much for your time, and hopefully this has been useful. Brilliant.
Thank you, both of you. Thank you for joining us. And I think that's a good inspirational start to our meeting. Thank you both. Okay, so moving on to item 2, just welcome everyone. Specifically, I want to welcome Andrew Gerder. So Andrew is CCG Chair for Bath, Wiltshire and Swindon. And I joined his governing body a few months ago, and it was a useful experience just to see how they operate and see what learning we can get from each other. So Andrew's doing the same. So he's here with a critical eye as well. So Andrew, we will be asking you towards the end of the morning for your thoughts and reflections, if that's okay. I've got apologies from Charlotte Burrows and Gaynor Appleby. The people who were joining late have now joined us because they were having a meeting with regards to NHS England. So I don't need to go through those names. We have one question from the public, and now that John Finn's with us, I think we'll cover that, and that's from Paul Walker. So Paul, if you are listening, then this is your question, and hopefully we'll be able to give you a satisfactory answer. And the question is, what provisions have been made to outsource and liaise with private providers to help reduce cataract waiting lists following the introduction of the increased capacity framework, which is being funded by NHS England? So I'll hand over to John Finn in the moment, who's got the details around that. But for those people who aren't aware, this increasing capacity framework, or ICF, as we like to give things acronyms, set up by NHS England, and it was basically to provide both commissioners and trusts a quick and easy route to contract and subcontract for with the independent sector for our elective services. It's meant that it's been much easier to get them to support us during this time, and in Devon we have certainly been utilising that ICF as much as we can to try and manage some of those longer waits, particularly in things like ophthalmology. But John, specifically around cataracts, if you want to give us an insight as to how we're working with the independent sector on that.
Yeah, that's great. Actually, we are making full use of the framework to meet the needs of our population, in particular in terms of cataracts, to ensure consistent waiting times across NHS and NHS use of the independent sector, rather than the use of direct referrals into those services. What we're doing with the agreement of all partners, including the independent sector, is that patients are being offered choice to be treated in the independent sector of current waiting lists. Now, by doing that, actually, what we have a consistent approach in terms of waiting times. Now, we still have choice. Now, this isn't mandated. All patients will be offered either to be treated in the NHS or in the independent sector.
Thank you very much, John and Paul. Hopefully that helps answer your question. Okay, item 3, register interest. That's as documented here. Any additions or alterations people need to make to their register? Good. And any particular conflicts of interest that people need to raise with regards to anything that's on the agenda for this meeting? No. Good. Then let's go through the minutes. If I go through the page numbers of the minutes themselves rather than the overall page number. So this is for accuracy. Oh, sorry, Judy.
Sorry, I was just trying to get in before you rushed through the pages. So when you come to page 2, may I make a copy?
Absolutely. And Susie? Susie, I think you're on mute.
Yes, it's accuracy, but I'll raise it when you go through the pages.
Okay, all right. So page 1, page 2, Judy.
So at the end of the comments from the guest speaker, we have down that Simon and Joe are going to give feedback, and I know they're going to, but I was wondering if we might, as a matter of habit, as a governing body, when we have a guest speaker and we agree an action that the team will take forward, that we could add that to the action log so that we just make sure that we don't lose these things. So much happens between one meeting and the next. And so that we as governing body know that there will be feedback to us. And I know it's going to happen, but it's not listed at the moment. So if we could make that a habit in our minutes, that would be, I think, very helpful for all of us. Thank you.
That's great. Okay, Judy, we'll do that. And actually then relating that to what we just discussed today, Nikki, I wonder whether you can capture an action for Andrew to work with Darren around agreeing a way in which we'll capture some of the learning from the volunteer workforce that we've had around the vaccine. Thank you. Okay, so and then there's page 3 and 4, 5 and 6.
I've got. So there are some words missing on page 2, but they're small. There's a much more important mistake on page 3, where the 600 figure is out by 3 decimal points. Page 7.
Yes.
Section 7, page 3.
Yes, we've vaccinated more than 600 people, I think is your point, isn't it? Okay, so Nikki, if we can adjust that to 600,000, well spotted. Susie, were there any others you wanted to pick up?
There was just a couple of little ones on page 2, but I can do that offline with Nikki.
Okay, thanks. And then John.
I can do mine offline. It's just page 6, bottom of organisation. It was a bottom-up organisation, which was one Ilfracombe. So I can change the wording slightly with Nikki.
Okay, all right, that's fine. Okay, and then page 7. So with those minor wording changes from those individuals, we'll take that as an accurate record of our governing body meeting held in March. Thank you. On the action log, we only have one action, which is about an outstanding briefing paper on MIUs and out-of-hospital urgent care, and that's been put on the forward planner for June 2021. Is that right, Nikki?
Sorry, Paul, on mute. Yes, as far as I'm aware, John Finn should be able to confirm. John, is that the correct month?
Yes.
Yeah. Okay.
Thank you.
All right. Okay. So so that's fine. So we'll close that when we've had that paper come through. Okay. The next paper is just really outlining what we've got ahead of us. I'm going to take that as read. It's there just to help. Yes, sorry, Judy.
We've skipped over matters arising, which is...
Oh, we have. Apologies. Yes, we have.
About
we have. So I just turned the page rather than following the agenda. So matters arising, and the only matter arising I have is a follow-on from the patient experience story from last week, where Debbie Francis presented to us, and Joe and Simon and Susie, I know you met with Debbie afterwards, and I think Joe, it'd be helpful from you just to give us a brief update on that meeting and any actions that we had as a CCG as a result.
Yes, very happy to do that. Thank you very much, Chair. Yeah, we do have, I have done a short written briefing as well, which if it hasn't already gone out, we can send that out to governing body members. So as Paul said, we met again, so myself, Susie and Simon met. It was a really helpful meeting. I think very generous again with her time in terms of just really filling in some of the detail around her and her daughter's experience. We did take a series of actions away from that, which was really helpful. So I'll just sort of clarify, they sort of broadly fell into three groups really. One was really to get involvement in the community mental health framework. So some of you will have heard about the community mental health framework and the work that we're doing there. And there are work streams within there are particularly pertinent to some of the areas that were outlined, so around personality disorders and also around carer support and also peer-to-peer support for individuals. So we're just going to link up that so that she could become part of those conversations with us, and we've done that through the working group, through the community mental health framework. There's also an action for us to follow up on personal health budgets for mental health, so that's an area we are actively pursuing at the minute with our mental health providers. And then there are probably a few smaller actions as well we are following up, and we're also just in conversations with Devon Partnership Trust just to follow up some issues that were raised around things like support to get back into employment, also care coordination, etc., when someone's discharged from an inpatient unit. So that they're broadly speaking, they're the kind of three areas that we are following up. So it was a really helpful conversation.
Okay. And thank you three for meeting with her. And actually, it sounds as though that was productive, and we've got some things that we can certainly look at as a result. So thank you for the three of you. Okay. So the schedule of what the governing body is achieved, it's just there so that we've got a list of some of the things that we are focusing on over the course of the rest of this morning. And so I'll go straight on to item 6, which is the chair's report. Three things I just want to pull out of there. The first of all, this is our opportunity within a public board meeting to welcome Jane Milligan, who is our accountable officer and is also the lead executive of the Devon ICS. So welcome, Jane, and I'll be handing over to you in just a moment for your accountable officer's report. And secondly, to thank and congratulate David and Matt, first of all, for agreeing to continue in your roles, in your joint role as the representatives of our southern locality, and to continue that until April, and also the affirmation that you've got from your member practices that support you in that role. So thank you for continuing with that. And my last point is really item 5. It fits with our patient story. It was a real honour and privilege to meet Roy Warnes, who is doing a very similar role in volunteering in Buckfastleigh and in West Devon, and actually to jointly meet with him with the Royal Navy to present him with an award and a thanks for his work. So if you haven't read his story, it's not long, but it is quite an inspiring one. So I'd encourage you to do that. All I'd say is don't mess with him, because he is still a black belt, and he did have to, despite being 88, still had to utilise that at one point in his car park attendances. So I took a step back and increased respect immediately from that point. Any questions on that report, John?
Just a quick question about process. As far as Matt and David go, congratulations to them both. They are a job share and they need to sort of deputise and change jobs between each other. Can we just make sure that they are both copied in to papers for the governing body and various other committees, so they're both fully informed? I think that'll make their job a bit easier.
Okay, I'll take that up with Nikki outside of this meeting. Yeah, okay. All right, in which case, Jane, formally welcome to our public governing body, and over to you for your accountable officers report.
So yes, and thank you. It's really great to be here, actually, finally. It seems a long time since I was appointed, but as you know, I have been dropping in and out of meetings until I started officially on the 1st of April. So, and I just want to say thank you to everybody for such a hugely warm welcome as well. I'm obviously at this stage trying to make sure I get out and about to meet up with people, and to sort of also get a grip and understand what business needs my attention too. And of course, I just want to say thank you to Simon and colleagues, but Simon particularly. And we have been working, as I say, very closely, and I'm continuing to look forward to working with him and everybody going forward. So in relation to the Accountable Officers report, I suppose a couple of things just wanted to, again, pull out really. Which basically reflects, I suppose, quite a lot to do between now and April 2022, recognising we've also got quite a big focus, as we will talk about later, in relation to our response, our continuing response to COVID, and the focus on recovery, but also in preparation for the next number of different phases that we will be working through over this next few months. I know winter has only just finished, but we will be starting to think about planning that very soon. I think very important as part of that is also about our focus on staff and well-being, but actually also ensuring that we've got a way, a mechanism for collecting our experiences from staff and our patients, particularly from the BAME population and communities. And as I say, that's been captured in a particular report which we need to take forward collectively. And then the other thing to say is certainly probably coming forward to the next board meeting, a bit more of an overview of our, as I say, our plan in terms of delivering the integrated care system and what that therefore means in terms of in relation to the CCG, and certainly working with colleagues on that. So, and just as I say, I have been happily taking up offers of invites to come and visit various systems or various PCNs or LCPs, and as I say, very happy to continue with that. I suspect it's going to take me a little while to do all that, but as I say, I'm very, very pleased to be here and to be able to continue to support the fantastic work that Devon has been doing and will continue to do. So thank you.
Thank you very much, Jane. Any questions for Jane on her report or anything that she's mentioned? No. I'm sure that getting off so lightly won't continue, Jane, but make the most of it on this first one. Okay, item 8, so 8.1, we've got the performance and quality report. Just so that colleagues are aware, the majority of our sort of assurance and challenge process around performance and quality happens within our subcommittees of our governing body, chaired by Graham and Glynis. But because, and we'll come to the CCG objectives, because performance is one of our key objectives and because of the challenges that we face coming out of the pandemic, we feel that it is a high enough priority for us to have extra visibility, and certainly we've agreed for quarterly for it to appear as an agenda item of its own right, rather than just through the chair's report. And this is the time that we're bringing it now. So Jane, you talking us through this one, and I'd ask colleagues to focus on the report. I know there's lots more in the appendix attached to it, but I think if we focus on data that we've got in front of us in the actual report. Jane.
Yeah, thank you, Chair.
Thank you, Chair. And I'll bring it, and obviously Darren will obviously contribute as well in relation to the quality elements. But if I just highlight some particular points, I think first of all, just to say this report reflects the period of data between February and March. Obviously, we're using the validated data where it's in this report. And obviously during that period, and it's really hard, isn't it, when you look back, so much has happened in our sort of turbulent last few months. But obviously this is obviously when we were going through our high number during February of patients with COVID in our hospitals, and obviously we went past the peak, and in March obviously have been started the de-escalation of our COVID capacity to enable us to start restoring services, and obviously that's continued. But also, it's been important to to note, it was also ensuring in terms of that start of that recovery is making sure our staff had time also to take leave and recover their own well-being too. So, and obviously that is a ongoing important priority. So in terms of the main messages of performance in this regard, in terms of our cancer services, we've seen in terms of the 62-day target, in terms of this period, this data relates to the end of February, a rise up to 75%, all trust improved, North Devon obviously reaching the 85% target, but obviously the recovery journey continues in that regard. Our 2-week wait position has been challenged. I've been reporting that obviously over recent months. That has improved up to 82%, but and has obviously subsequently the issues, particularly around the breast symptomatic standard, which has improved, but there are underlying challenges there in relation to demand and capacity, and work underway in terms of mutual aid support in that regard. But to give reassurance to governing body, we've also obviously the delivery of what is referred to as the faster 28-day standard from referral to diagnosis is being maintained. But there is obviously more work to be done, particularly in terms of our restoring services and our collaborative working, and obviously that's supported through our mutual aid work and of course the cancer network or Cancer Alliance. In terms,
Jane, I think Susie's got her hand up. Is it a cancer?
No.
Susie.
So I'm very happy to go right at the end, but it's not to do with that. It's more with children's actually. But thank you, Simon.
Right. Sorry, Susie. Sorry, Jane. Okay,
thank you. In terms of elective care position, John Finn's already referred particularly to the independent sector in the answer to the question that we received. So obviously the arrangements with the independent sector has moved now back to our normal contractual arrangement, but we have set out in the report our focus in using that capacity is ensuring that we are treating our long waiters as the majority of that capacity for our long waiters that are sitting on our trust waiting lists, and that of course is about ensuring that we're trying to achieve equity in terms of making of our total use of capacity in that regard, and that's obviously really important. In terms of obviously our waiting list position, as expected, our long waiters have increased, and we know that is obviously the underlying trend in context of the COVID pandemic, and obviously our major focus as we move forward in looking to improve that position. Our over 52-week waits between the differences between the months reported here increased overall by just over 1,800. And I think that obviously harm reviews are really pivotal to this, and all trusts are undertaking those harm reviews to ensure that risk assessments of patients who are sitting on long waiting lists are undertaken on a regular basis. What is obviously that's our major plank as we move forward in terms of our recovery and planning in relation to utilising our capacity to deliver improvements, particularly on our 78 and 104-day waiters. Diagnostics position. Obviously, we've had a little bit of improvement here, but obviously a long way to go to recover. What's obviously really helpful in this regard is our use of Nightingale. Now, obviously, it's not in use for COVID inpatients, and we've got the additional diagnostic capacity operational within that facility, and obviously work underway about potentially expanding that further. And I think that's obviously really important in terms of maximising our capacity going forward. In relation to urgent care, and as obviously we're obviously looking here at a position in February and March, but also looking forward, our challenge is actually ensuring that we keep the system in balance in terms of providing the appropriate urgent emergency care response, but within our level of capacity that enables us to ensure that we can recover our elective planned capacity. So we've obviously seen now, obviously as lockdown has eased, an increase now in relation to demand coming through, particularly walk-in demand. You'll see how the numbers have increased in this report in relation to attendances just in this period of time between February and March, and we've seen that increase further as you would expect. The challenge, of course, though, and we mustn't lose sight of, is that our providers are obviously having to operate both obviously for elective and for urgent emergency care in the obviously maintaining both the COVID capacity and pathways, but also ensuring the appropriate social distancing, infection prevention control arrangements, which obviously adds to constraints in terms of our productivity and our capacity. In urgent and emergency care, we've had obviously flow is really pivotal in terms of our response. So we have been challenged both regionally in terms of our levels of performance in relation to urgent emergency care, particularly in relation to ambulance handovers. And obviously we've been reporting on that over recent months. And that has been a particular challenge in the Western system for UHP. What we've have seen some significant changes that Plymouth Hospital have made over the last month to their organisation of their pathways and arrangements for handovers from ambulances, which has led to quite an improvement. But we're not out of the woods yet, and we've had some, because of the rise in demand, particularly over the last week, we've had some problems in relation to extended delays again. But just to give a sense of the scale of the improvement, just to point out from the report, they measure for over a 30-day rolling average for the minutes lost in handovers between 30 and 60 minutes. It's dropped from 828 minutes at the 18th of March to 286 at the 11th, which is a phenomenal improvement. But as I say, still plenty more to do, and there are still challenges to be worked through in that regard. The 4-hour performance is obviously an area of focus too. Plymouth are not measuring that standard because they were on the pilot scheme for the new standards that we expect to be rolled out later this year, but particularly RD&E have been challenged on that standard in this period and more recently, and there's an improvement plan in place to address that. But once again, it's a reflection of demand and flow. We've got significant work underway in terms of being able to deliver in flow through improvement plans that our localities have developed to actually ensure that we are building on the discharge to assess model and looking at flow all the way through the whole hospital and beyond in terms of the management of complex discharges. I think perhaps I might just pass to Darren to pick up the quality aspects at this point and then come back and cover off some other areas in relation to mental health and children's.
Yeah, thanks, Kat. Thanks, Jane. And then we'll take questions once we've done that.
Yeah, thanks all. Thanks, Jane. So I think you've probably in the main covered the main areas of quality that I wanted to address. I think the areas to really draw the governing body's attention to is obviously the work around the risk profile, but also risk stratification and harm. And I think that we need to be looking, and I know we're working at the moment, is that we need our clinicians to be working and reducing the weight and the backlog. So it's about how we have a process that gives us a level of assurance, and generally our level of assurance is good around the harm profile, but actually want to get much more proactive. So I think there is more work to be done in that particular area to really understand the psychological as well as the physical harm, but also in terms of an early warning system to make sure that we can re-stratify our individuals waiting longer than we would like and expect. I think the second point for me is the point that you also referred to, Jane, is that despite really good improvements in UHP or University Hospitals Plymouth around lost ambulance time, we still have significant amounts of lost ambulance time in Devon. That has a wider community quality impact because ultimately we have a large number of individuals then waiting an ambulance response, which is a really unquantifiable risk element, but clearly is an area of quality that we work with SWAS to understand, but need to do more with based on the report. And then I think finally for me, the infection prevention control elements as we start to move away from the pandemic. There is a real understanding here of the impact that we have on organisations in terms of social distancing. Obviously, things like visiting, etc., have now started to open up. So that has further impacts on flow and our facilities. And equally, I think the thing that we need to be really mindful of, even in the report today, though we're now starting to see reductions in prevalence, we are still seeing outbreaks in a number of areas, and as we start to see those areas of relax, we will also see our other IPC challenges coming back on board, such as norovirus, such as flu, which we really haven't seen any impact on over this winter. So I think for me, yes, that we are in a good position from an infection prevention control point of view that has had a clear impact, but ultimately we are having a heightened level of surveillance in that particular area to understand what our next challenges will be. But I'll hand back to you, Jane, if you like, on mental health and children.
Okay, thanks, Darren. So in this report, we've put a narrative in relation to our position in relation to mental health and children's services, and I think probably we've got obviously a picture here in terms of mental health where, and I think once again being cognizant of, I think our colleagues have described it as in the summer often is the mental health surge period in terms of demand. So we're obviously looking very carefully in terms of obviously the work that Joe and colleagues are leading in terms of the mental health commissioning and support around mental health transformation is about ensuring that obviously we've got the capacity in place to respond to that already increasing anticipated demand, both in low level need and in higher level need. One of the areas particularly I think of concern at the moment, and there's obviously a plan in place in terms of increased capacity to address, is that we're not delivering the access targets in relation to both eating disorders access for urgent and routine. And obviously, because of the high risk nature of those cases, it's important those targets are very stringent. But there is a plan in place to increase capacity. And I think what we know is that is an area where we have seen increased demand and need as a consequence of the pandemic and stresses that brings. But there's also positive in relation to learning disability. I know the data's not all in yet, but in terms of the checks, the physical checks, that's progressing well, and we're confident of good outcome in terms of our target in relation to the Q4 position. Children's services, and I know this was being discussed at obviously the Quality Committee, and no doubt come through later in terms of the quality report, but obviously there's this long-standing issue in relation to access in terms of diagnosis, assessment for diagnosis of autism, and obviously a huge amount of work underway in relation and capacity brought to bear to address what are obviously very challenging long waiting times, and similarly in relation to speech and language therapy. So obviously these are services that are really fundamental in terms of meeting children's development needs, and obviously there's a significant attention on that as a system to address improvement. And I think finally, I would just want to flag up, in the report, we obviously are still reporting on the phase 3 schedule of improvement, which is obviously activity based. We're obviously working on the operating plan at the moment. And obviously once that gets finalised, we'll be obviously monitoring against our new trajectories that fall from that plan. And also just to say that in the report, we've outlined here our sort of way forward in terms of performance improvement monitoring, both in terms of our system approach, in essence that we're trying to get to a place now where we've got a very clear line of sight from place, our LCPs as they develop, where performance review and a focus on improvement collectively in terms of is going to be facilitated and supported with the use of an integrated performance report. So we're looking at all our information in the round, whether that be obviously our performance against some of these our key metrics, our quality domains, fundamentally focused on outcomes and bringing in all other aspects in relation to workforce and finance. So that work is an evolution process, I think it's fair to say, but from that process, from that review, that will feed through to our system performance group and then feed through to governing body, as well as to the ICS partnership board. And as I say, we envisaged that over the coming months, that will basically be a process that will evolve and develop as we bed in those new arrangements. But I wanted the governing body to be cited on that sort of transition period that we're in. But the fundamental principle of that is absolute line of sight in escalation terms of where at a system we need to ensure that we've got the system traction to address issues of risk and performance improvement. I'll stop there. Thank you.
Jane and Darren, thank you both very much. We've got a number of hands up, so I'm going to take them in batches if we could, just for time's sake. So if I can go to Susie, then Glynis and Graham, and if we take those three and then go back to Jane and Darren. So Susie first.
Thank you very much indeed. Thank you for the report. There is central guidance requiring requiring clinicians to take into account BAME identity and social deprivation in tackling the waiting list backlog. Are we clear how clinicians are doing this, how they're balancing those factors with acuity, and whether it's being done in the same way across the system? It's my first question. My second one relates to children's services. Clearly, we've got more than 3,000 children waiting for speech and language assessments. Almost half of those have been waiting more than 18 weeks. We've got more than 3,000 children waiting nearly 3 years for these assessments. These are completely unacceptable waiting times, and they've obviously been this way for some time. It seems that there is now going to be a more concerted attempt to tackle these. What I think we need to do is model the trajectory for recovery extremely carefully, and then monitor that very, very so we understand exactly what we can expect by way of the reductions in those waits, and we can jump on this extremely quickly when we don't see the modelled recovery, because this can't go on. We already know that our kids do worse in speech and language very often than other children from deprived backgrounds are doing worse already pre-COVID in Devon than in many other local authorities, comparable local authorities. And as we saw from a national report this week, speech and language has been one of the things that's been most impacted by COVID on young people. So I think we can expect, we know we're already really bad at this. We're going to get even worse. We've got to really keep tabs on this extremely closely.
Thanks, Susie. There are a large number of hands up, so I'm going to ask when I come to you if you can be as concise as possible. Glynis.
Yeah, just to answer Susie for a minute there, just to say the Quality Committee has been very concerned about this issue, and we are keeping sort of tabs on that trajectory now. At every meeting that we have a report on children and young people. My question actually was about breast symptomatic, and I realise that these figures are from during the pandemic, but actually this has been a very volatile performance, an area where there's been very volatile performance for a long time, so it's not just COVID related. And I would like to know whether we are providing, or whether support is provided to women who are waiting for an assessment and it goes beyond the weeks, because I think there's a harm factor there which we're probably not registering.
Great, thank you. Then it's Graham, and then we'll go to Jane and Darren.
Thank you, Paul. I think my point is a more general one, but it builds on what Glynis and Susie have just said. Finance and Performance Committee have been used to having these reports from Jane and her predecessor for some time. We're all familiar with all the stories about the cancer waiting times and the RTT and the ambulance handovers. I won't rehearse them all. And we know that there's been a COVID effect, and that our recovery is restricted by social distancing and staffing issues and so on. I just wonder whether we ought to be reflecting on the fact that our performance before COVID wasn't perfect. We were challenged in many areas. And I wonder if we need some sort of position statement that compares where we think we are now and what we think our trajectory is going to be with where we were pre-COVID, because we've had a year of looking at these figures in a COVID context. And I think it would just be useful to refresh on where we were pre-COVID and how that's going to be affected by the pressures of elective recovery as well. Thank you.
Thanks. So Jane, I think if you can pick up, there's certainly things around BAME and social deprivation, how that's affecting our waiting list assessment. What are we doing around support for those breast symptomatic people on the waiting list? Graham's about how we might rethink our trajectory compared to our pre-COVID environment. And I think the children's point is well made, and Glynis, I think it's helpful to say that actually we've got that in our quality committee, but then I think Susie's challenge for us to take away is to think about how we might keep a closer eye on that and try and actually turn the tide a little bit, I think was your challenge to us. So probably not something we can answer here, but a challenge that we need to take on board. So I guess it's those three other elements to pick up, please, Jane.
Okay, yeah, I think in terms of the issue around the inequalities and the impact in relation to, I think Ginny's offered to pick up that particular point in terms of that first question about the waiting lists.
Yeah, and I think Nick may want to come in as well. So just very briefly to say that there's a lot of work going on both regionally and nationally to identify good practice and how we might do that. I think everyone will appreciate that and very complicated thing to do. And there's a couple of NHS England events, both this afternoon and tomorrow, where we've got representation to get some more guidance on exactly how that might be done. Nick is taking, so we're putting together some ideas, and then Nick Kennedy is taking a paper to the Clinical and Professional Cabinet on, I think, the 13th of May to get views from other clinicians on how we might take that forward. So at the moment, it's a very kind of patchy picture, and we're trying to work out the best way to make sure that we do that appropriately.
Thank you. Do you want me to add something briefly to that, Paul? Jen has summed up pretty much what I was going to say. I think the only other thing we may want to do at some point, Susie, is take it to the ethics committee as well. If we feel that it gets to the point that clinical decision making may be impacted by it, so we'll come to you. We'll go to clinical cabinet first. The other thing I'm doing, I'm also working on this in the Bristol system, so I'll get two views on it. But there's a lot of work going on around this.
Okay.
Thanks.
Shall I pick up the point around the breast standard, the asymptomatic? I think it's a complex picture in terms of both demand and capacity, because there's been some issues in relation to staffing availability, obviously not just COVID related in terms of capacity, but also other factors, and some good work to mutual aid. I think in terms of management of risk, I think the 28-day, obviously the situation's improved, particularly in terms of the RD&E position in relation to the 2-week wait target, as I pointed out in the report from this data. But the 28-day faster diagnosis standard is really important. Is obviously really important in terms of that being ensuring that all referrals, people receive their diagnosis within that 28 days. So that gives us sort of a backstop position, and that is being maintained in terms of the management of risk. There is, as I say, further work, and actually Nick might want to comment from the sort of mutual support group actually in relation to trying to work through how we can balance off some of the demand pressures in that regard and available capacity. I think a lot of this then obviously ties back then into the surgical capacity response as part of recovery. But Nick, did you want to add anything in that regard?
Well, the mutual aid group is a group of senior clinicians and senior managers from all the providers around the region with CCG input. We meet every week in conjunction with the surgical restoration group. The membership is very similar, and we have sight of all the issues around mutual aid requests that are either in place or that may be coming. So I think we know in advance really where the problems are. I can update you on the current problems if you want, but perhaps not for this meeting. Yeah. But it's a weekly meeting, and we're putting a lot of effort into, and it's actually a really very cohesive meeting, and the amount of goodwill and support that is given by all the providers to each other is exceptional. Really, it's really good, and I think it works very well, and it links into the cancer network as well.
Thank you.
Okay. And then, just sorry, I was just going to say Graham's challenge of looking at our trajectory through a slightly different lens, through a pre-COVID lens. Yeah. If I take that away, I think would be helpful to think about that one rather than trying to answer that.
Yeah, no, I would agree. I think that's a really key point, and it's something that we've been talking through actually this week. When you try to do any comparison through the last year, you can't, obviously, with COVID. So we have to go back to where we were 19 and obviously recognising, obviously part of the operating plan work is very much, we'll bring that to bear in terms of our trajectories for next year. So that will follow through. But we'll come back on that one, particularly in terms of the Graham's ask.
Thank you, Jane. So can I go to Sheila and then Alison and then John W.
Thank you, Chair. So just I have 3 points really. One, my original point, and then 2 others. So the first one is a request that when we are looking at things like flow in the system, it would be really helpful if we could have a little bit of reference to primary care as well. So page 39, Jane, the statement that says trusts are reporting an increase in GP referrals to ED, which is contributing to the challenges they are experiencing, etc. What it doesn't reflect is that that's not because GPs have suddenly decided to ping in a load of extra referrals. It reflects the workload. I know I go on about this, but we need that system approach because it's really important. In the Western system at the moment, we are functioning at 13% over pre-COVID levels in general practice. So it is very relevant and very live for us at the moment. So I just wanted to respond to Glynis's point about the breast symptomatic pathway. Can I give you some clinical assurance, Glynis, that women who are referred to that pathway generally have very vague symptoms, and if we have even a hint that they might actually have anything serious, we would refer them on the 2-week wait, not the symptomatic breast. And we had a situation back in Plymouth, it must have been about 3 or 4 years ago, it was right at the beginning of mutual aid, where we actually where we did have significant delays. I think our breast symptomatic pathway wait was about 7 or 8 weeks, and we audited every single referral, and the pickup rate was very, very low. It was less than 1% in that population. So I think in terms, not obviously that doesn't address necessarily anxiety, but I think in the consulting room, by and large, that will be addressed by clinicians who are doing the referral and being very clear about the situations in which they're being referred. And thirdly, I just wanted to pick up about the eating disorder in children. That is of concern. Now, I'm currently doing the mental health clinical lead role. I haven't had any sight of the issues with children, and I wondered whether I could see what the plans are for the 2 providers. I'm assuming, Jane, that those are Children and Family Health Devon and Live Well Southwest. And is that up to age 18, and can we be looking also at eating disorders in adults, because I think that is also an area that is really pinched, not just at the moment but particularly increasingly pinched, and I would like governing body to ask to be cited on that as well. Thank you.
Thanks, Sheila. Alison.
Thank you, Paul. We've already said that Quality Assurance Committee are looking at the autism assessment waiting list, but Susie picked up on a point in this report. There's a figure in there I've never seen before. We've always been told about the average waiting list of 81 weeks. I've never seen 139 weeks as the maximum waiting list. And so mine's a request really that when this comes back to quality again, instead of just getting an average rating time, could we have it broken down into how many children have been waiting 6 months, 12 months, 18 months, 24 months, so we can really understand what impact this is having on families. And then my other point is quite separate. It says there's an unprecedented number of referrals for adult safeguarding reviews this quarter. And I just wondered if we knew why that was. Is there any pattern that we should be responding to? Thank you.
Thanks, Alison. And John W.
Thanks. So my eating disorder question has been asked by Sheila, and my other question was around A&E waiting times and linked into the GP referrals into ED. Jane, with UHP not reporting, are we blind with little sight of what's happening within UHP? Because if we're aware that there are some challenges in primary care sometimes in Plymouth, and that can spill into ED. If we have no sight of what's going on in ED in UHP, is that a problem, or is it addressed in another meeting regionally or whatever, as part of the pilot, I suppose? Thanks.
Okay. So thanks. So Sheila's, I think we take that what you said about the breast pathway as reassuring. I wonder whether, Jane, you can take the issue around the eating disorders in children offline with Sheila and work through that. Would be helpful. Sheila, I think your point about primary care is well made, and there are meetings, and I'm part of those meetings, trying to work out how do we get objective ideas and then incorporate them into our performance reports about the activity in primary care. As I'm sure you can imagine, it's not easy to get that, and it's something we've been trying for a long time. But I would hope that actually going forward, that's certainly an ambition that should be part of what we look at as overall system activity. So I think that one's a work in progress, but a recognised important one that we need to sort out. Alison's got a request about quality reporting, but then there's the two issues I think, Jane, which you could pick up now. One is around what do we know more about the safeguarding adults issue there, and John W.'s what sight have we got of UHP's pressures there?
I was just going to pass to Darren on a safeguarding question, and I'll pick up the UHP one.
Yeah, thanks, Jane. So yeah, and thanks, Alison. So I think at the moment, looking at that quarter's data, there's a little bit, it's too early to tell if we've got any real significant themes emerging, because actually there are some real variances in those reports. However, this does feel directly related to obviously the impacts of the pandemic, with obviously less eyes on from a clinician point of view as we're starting to come out of lockdown, etc., etc. So I think there is definitely a correlation here, which unfortunately I think we reported at previous governing bodies that was a concern that's now coming into fruition as we come out of lockdown. We're now starting to see these individuals coming to our fruition. So I think that's an area to watch, and we'll make sure that comes through in the updated reports going forward. I'll also pick up the Quality Assurance Committee action, so leave that one with me.
Okay, thank you. And then UHP, Jane.
Yes, so to give assurance, John, and to governing body, there is significant scrutiny in relation to UHP performance in terms of urgent emergency care. Yeah, right. They don't monitor against the 4-hour. They're part of the national pilot. We do see sight of that information, and what we are reporting on. We have a system in place, a regional system on a daily basis, where certain triggers are breached, and those triggers would include ambulance delays over 10 hours, would include status in relation to escalation, any 12-hour breaches in terms of decisions to admit, as in people waiting in ED more than 12 hours. And so and we have I'm chairing the Urgent Care Forum in the West at the moment, and we have significant oversight from region in relation to the urgent emergency care position. I think it's fair to say particularly the last week and early part of this week, where UHP experienced a very high level of walk-in activity, which created a very bad day on Monday and Tuesday in terms of pressures. And what it's trying to work through is going back to the point that Sheila made, and I totally accept. We're got to move from anecdote to fact, recognizing the whole system is very pressurized, and trying to understand different behaviours now with the different channels of access that people have within primary care, digital, as well as face-to-face, and behaviours in terms of people turning up to ED who may be able to use alternatives. So there's a huge amount of work looking at that in terms of the improvement plans in that regard at UHP, with significant oversight and scrutiny.
And just finish off. So do then look at harm for some of the, if those triggers are activated, does that then link into Darren's work?
Indeed, all 12-hour breaches are reviewed by Darren's team.
Great.
Thank you very much. Thanks, Jane. Got Simon, and then Simon Kerr, and then David.
Yeah, thanks, Paul. Thanks, Jane, for the report. I suppose what I was looking at was our second objective is about improving service performance, and looking at certainly some of the performance in the East at the moment is kind of worrying. What I was really wanting to see in the report, I think, was more evidence that we are taking strategic intelligence to our local care partnerships to help them to make the right decisions, to improve their capability and capacity, and some I guess narrative about what the enablers are that we're giving to our local care partnerships to do exactly that, to increase their capability and capacity. One of the things that worries me is we were very emphatic about digital 18 months ago and how wonderful that was going to be. I think that digital has created, certainly in primary care, a demand for on-the-day advice when it's maybe not needed on the day, and also it has changed continuity of care so that we can't provide such continuity of care as we used to do, which ultimately results in people maybe not getting the service they need and defaulting into secondary care, defaulting into referrals that maybe wouldn't have been made by somebody who might have known that individual more thoroughly. So I think what I'd like to see in this report is some evidence-based strategy support for local care partners and clinicians on the ground, so that they can do what we want them to do, which is improve service performance. The other point that I'd like to make is about enabling capacity, and that's about space. We have a lot of community hospital space in East Devon, which is vacant, which we're paying a huge amount of money for to NHS Property Services, and that's stalling our ability to move forward, particularly with outpatient clinics in parts of my patch. What can the CCG be doing to enable that conversation with NHS Property Services for us to use that space more productively? Because I think that will help us to drive down waiting lists and also to improve service performance. Thanks.
Thank you, Simon and David.
So I just wanted to make two completely unrelated points. The first is really just to ask that we are really proactive in the way that we speak to GPs about managing the long waiters. And we're getting to the stage where actually the majority of people will be having a really significant wait for hospital treatment. And remembering 20 years ago how we managed that, it did tend to be that people who complained the most got the most weight of GP letters to their consultants, who then felt pressed into pushing them up the waiting list. And as we came out of those long waiters 20 years ago, it was apparent that treating people chronologically in order actually got through the backlog much more quickly. So actually prioritizing people delays the time at which you get out of that long waiting period for everybody. So it's really important that we communicate with GPs how we're going to prioritize people who are waiting a long time for treatment, and ask GPs to, we need some sort of framework is really what I'm saying, some sort of measure of harm of how we're going to avoid people getting unfair advantage and overall pushing the problem down the road. So really, it was a plea that we communicate with GPs really clearly about how we're going to prioritise patients who've waited a long time. My second, completely unrelated, was about the long waiters, people who are waiting a very long time for psychiatric assessment, particularly autistic spectrum disorder and ADHD. Just to say that we're starting to develop a problem with a number of private providers who are available for choice. And Devon CCG has a policy in place that it will only allow choice where the provider is providing the full pathway, not just a diagnosis. There are a number of providers who are operating online just to provide a diagnosis and no other service. And there's starting to be a bit of tension. I just wondered if other people had come across this problem and exactly what our legal position is related to denying patients choice on the basis of either that it will prolong waiting times for other patients, or that it doesn't provide a full range of services.
So thanks both. So Simon's, I guess, is what can we do around empowering LCPs to manage some of those pressures locally, and particularly around what intelligence and support can be provided. And then the other one is around, are we making the most of our estate and how can we maximise that? I think, David, there's a communication thing around GPs. That may be something that needs to be taken away. But Darren, certainly one for you around, you know, what is our process about assessing harm? And then, David, there's that challenge around those emerging providers for the diagnostic process around long psychiatric waiters and how we manage that. There's a handful for you, Jane and Darren.
Okay, thank you. I'm just thinking in relation to this, I'll pick up this strategic intelligence point, and I'm not sure if we've got, we can bring Kelvin into that if he's available. But so what I just want to say on that one, I think it's definitely, I totally take the point, Simon. I think this is very much evolution. I think it's sensing what we're trying to do as we develop LCPs. Jane and I had our, Jane joined my team meeting with locality directors yesterday, where we were talking about the LCP development and performance improvement approach, and also, you know, what it takes to make that work, in both to have the right focused conversations on what makes a difference. So where do you, in all this plethora of information that we have and data, getting real intelligence, and that is going to take a lot of support and input and nurturing in terms of being able to make the best use of the clinical time that colleagues have to work on these issues. So I think it's work in progress, and I think probably working with my sort of answer to that is we need to almost be able to come through with the priority areas in each of the localities. And I know in the East you've done some work already. I was hearing about some of the conversations to try to prioritise the areas to look at, to actually then we could then bring the intelligence to wrap around it. So as well as identifying it at source. So it's an ongoing, you know, we're not going to crack this overnight. This is going to take a bit of effort to line up our resources to ensure the right support and intelligence is at place. But I think that to me is an important journey. Is that a hand up, but I can't see who that.
That's Nick Ball has got his hand up, but we'll come to that in a minute.
Okay, sorry.
All right.
But yes, I think that's an ongoing. In terms of the estate point, and I might bring John Finn in on this one in relation, because already that we've been looking at the estate in terms of how that could be potentially used as part of recovery. So there is some active work underway on that in terms of maximising the use of the community estate.
Yeah. Okay, I think, Simon, you'll do yourself the inroads in terms of urology, in terms of community hospital capacity in East Devon, which are hoping to mirror around the county. I think also in ophthalmology, I think in a very, very near future, we'll be able to describe how further outpatients, both in diagnostics and imaging, will be putting into community hospitals, basically. So happy to pick that up with you after this meeting next, but definitely plans in place around recovery in both those areas.
And in terms of the point around I think Joe wanted to pick up the point around the choice issue.
Yeah, thank you very much, Jane, and thank you, David, for the questions. I think it is an area that's just been putting some increased pressure on general practice, and I think there's a real concern from general practice about inequity in offer to patients. So we made a decision through our clinical commissioning committee that we will put in place a policy which is in line with NHS constitution, So we have an absolute right to be able to say as a CCG that we want to commission a pathway approach. So the service offer that's on offer from independent sector is only a very small part of the pathway, and it is also a part of the pathway which doesn't offer ongoing treatment and support or medication. So a significant issue in there that general practice have highlighted for us. So as you say, David, on 3 grounds, we've made a commissioning policy. So based on the fact that these services aren't offering the whole pathway for patients, based on the fact they're not offering that at local tariff as well. So that is another key area we would expect any other provider to be able to match local prices. And then the third area as well is of course that reducing the inequalities. We've got a strong belief, fed from feedback from primary care, that probably individuals that would be referred to independent sector are probably more than likely going to be from a certain demographic within the population. So the feeling is that this would only extend the health inequality that we've got in this area as well.
Okay, thank you all. Can I have the last word on this? I think it's thank you as a collective. There's a lot of questions that have come through, and thank you to all the execs who contributed to that for helping us to understand and unpick it. I think the time we've spent on it, I know we've gone over, but it reflects the importance, I think, to us of some of these performance and quality challenges that we face, and the responsibility that we feel and should feel for our population around those services that we commission. My last point, however, is to say thank you to Jane, because that's your last performance report that you're going to be presenting, at least for the time being, until we tempt you back for the CCG. And just to say that thank you, although it's been a relatively brief time, the work that you've done in your role for us has been exceptional. So as on behalf of the governing body, thank you for the work you've done. People who are looking at me confusingly, it's because Jane is going to be moving to support the integration of acute and community services over in West Devon and Plymouth area. So thank you, Jane. Thank you for your time, and all the best with the next challenge.
Thank you.
Andrew, can we move over to item 8.2, which is the CCG objectives? And can I thank you for producing actually what I think is a really helpful, well laid out report that captures the essence of the objectives that we collectively agreed with our staff, and actually presents in an easy to read way some of the work and how we're progressing on that. So thank you for that. But I'll ask you if you can take it as read, but highlight the things that you would like to, and then we'll have an opportunity for comments and questions.
Yeah, thank you, Chair. Thank you for your comments. I guess that the work has been, I guess, co-designed from the start. So we've done as you know, we've always had objectives for the CCG, but actually for the first time we've co-designed those with staff, with you, and for the first time we're presenting a report that hopefully highlights progress, and we'll do that on an ongoing basis. The first report, I guess, highlights where we are with our 5 main objectives, and you'll see the assessment that directors have come up with for each of those 5, and importantly some of the actions that sit below the 5 objectives. That's really important because we wanted, I think, things that were really specific and measurable that we could assess. So myself and Nick Pearson, who works in Jane's team, really have put this work together, and we've worked very closely with the directors who've been nominated as leads for each of the 5 objectives. I just wanted to note from John and I's perspective that you'll remember that we had the CCG annual assessment, and there was a report produced with some actions in there. We've now actually put those within this report so that we're not reporting twice. I think that's really important because that will give us clarity as we go forward. I won't cover all the elements in detail, Chair, because I guess it's fairly self-explanatory. We've tried to keep it simple. We've tried to keep the process simple. It's been through our exec team meeting and through SLT. There was some debate around the RAG rating, but I think the RAG is clear, and of course we can make adjustments to those as we go forward. For me, the important thing really is it gives us a sense of where we are with our main objectives for the year ahead, and the progress that's been made and the mitigation actions that are there. But given it's the first report, Chair, I'm quite happy to take feedback really from members about whether there's anything we need to do to adjust it, to improve it, or to clarify any point. And myself and my fellow directors are happy to take any questions on any of the specifics within it.
Thanks very much, Andrew. So Nick Ball has got a question.
Thanks, Chair. Andrew, thank you. This report is really helpful, and I hesitate to ask you to add more detail to it because one of the things that makes it helpful is it's really easy to read. But I wonder if we could add either some more narrative or a column that deals with the kind of so what question. So just to pick an example, but it is just an example. Under action number 2, adapt and adopt, we say that we've got an adapt and adopt program fully implemented across trusts in Devon. But what are the consequences of that, and what is the problem that it's solving, or what is the innovation that it's creating, or whatever? And I think something that just shows the output would be really helpful.
Happy to do that, Nick. Thank you.
Cheers.
John.
You're on mute, John. John. You're on mute.
So you didn't hear me say what a wonderful report, Andrew. Thank you very much.
I missed that bit, John.
So I think one area, my question is really about the process. One area where I think the NHS could do better is the early involvement of local people in the development and the co-design of services. Should we consider that one of our objectives might be to be champions within the system of that early co-design of services with local people, or do you feel that's inherent in some of our objectives anyway?
I think, John, it is in there in objective 2, the final one. But if you want me to make that more specific, I will do, because it is all about that. We're trying to, and indeed we'll have a big programme going forward, won't we, on the long-term plan implementation, where we will want to engage and co-design work with patients, service users and the public. So I'll make that a bit clearer, John, if it hasn't quite stood out in that way.
I think that'd be good for local care partnerships, which is where, of course, a lot of this work will take place. To have that really spelt out will help us create a change in behaviour in all aspects of everything we do, which would be good. Thanks.
And I meet, John, just to add to that, I meet with the local care partnership comms and engagement leads every other Friday. We've got 4 of them. There's the Western one, we still haven't got a lead yet, but I've been liaising with Derek on that. And what we'll do is work together on things like the long-term plan, where we're doing some system work in engagement, but also doing it at LCP level.
Thanks.
Thanks very much, Andrew. Sheila, let's last question, then we'll move on.
Thank you. Yeah, so I just wanted to congratulate Andrew on the report, but also specifically I want to congratulate Andrew on the work that he is the lead director for around the work with staff, because certainly I've been knocking around this CCG and our predecessor for 6 years now, and I've really seen that the focus and the attention on supporting staff has really gone from strength to strength, and Andrew, you're responsible for that, so thank you. My question, if I can sneak an extra one in, is to Jane, which is how is that going to be translated and carried forward into the ICS, Jane?
No, well, good question and good point. And as I say, I have to say I've been incredibly impressed with the work that has happened with staff. And in fact, I joined the staff forum last week. From my perspective, it's going to be front and centre. And I think what's important to me is when we working with Simon as part of our sort of, I suppose, next phase plan, if we call it, in the evolution of CCGs into ICSs. Having that strong staff being will be really important, and ensuring that you know, obviously we want to sort of recognise a slightly different way of working, but to take forward the fantastic work we have been doing, and in fact the work that Simon and others have already been putting in place to sort of get the different teams fit for the future. So I have a huge, and hopefully others will testify for that. Certainly, we can't do this without our staff, and it's a very, very important priority for me.
Thank you.
I think Simon's hand pinged up there. Yes, I don't know. Hopefully he's not going to contradict.
No. Absolutely not. So Sheila, we're intending making staff engagement and communication one of the work streams in the ICS development programme. So it's not just CCG staff, it'll be how we can engage properly across the whole system. I was speaking to somebody that's interested in coming to work for us, and we were talking about ICS and CCG transition, and I did say we will definitely make sure we get that staff engagement right, even if I have to go and speak to each person individually to make sure that we get it right. So we will do that and carry that through, Sheila.
Thank you, Simon, and I was very remiss in not acknowledging your leadership on this as well. So whilst it was on your watch, thank you.
Thank you all. We'll move on in just a moment because I know Derek has joined us. Just before we do, Andrew, can I just ask, on the RAG ratings, Action 6, which is around the development of the 5 local care partnerships, I suspect in a moment we will have a conversation about the West Devon one, and I just wonder whether that's genuinely reflected in a green RAG. Maybe want to reflect at the outcome of the next conversation rather than to open up now. Because I know that there has been, some challenges around getting that local care partnership up and running.
Recognise that, Chair, definitely.
But rather than preempting that, I'll hand over to Derek in just a moment. I'm just going to ask people to take the other LCP reports as read. But just to note, John, thank you for that comprehensive information around One Northern Devon. It's really helpful to see just how much work is going on there. We haven't got time to go into detail, but I think it was really helpful to read through that, so thank you very much. Derek, if we can come to you now to talk us through, and our focus this month is on Southern and West Devon.
Thank you, Paul, and thank you to everybody for inviting me. So just in case people didn't know who I am, my name's Derek Blackford, and I've recently taken up the role of Locality Director for South and West, so a joint role between the CCG, Devon County Council and Torbay Bay Council. I've sent the documents, so one in relation to the West LCP and one in relation to the South LCP, which are the latest drafts of the sort of framework document as the LCP evolves, which I'm sure it will continue to. And I've also sent the usual locality update, which I wasn't planning to present or read aloud to you. And you will have had the opportunity to go through that yourselves. Just to make the point at that stage that obviously I'm working quite closely already on the South locality update report with Judy and David. And I've started the same with Sheila and Nick and Anna from a West perspective, because obviously conscious of the fact that there's a Western system locality update which comes to you is probably separately on the agenda. So we've got to work quite closely together about aligning or separating those reports to the extent that's useful moving forward. But at the moment they are the same, but we are working quite closely together about obviously how that feeds through, both in terms of governing body update and to the ICS Partnership Board as it evolves. So I just wanted to make those points at the start. Obviously, I want to leave opportunity for question, conversation, and any feedback on what I've shared in the documents and what we discussed. But just a few things I wanted to make the point on, I suppose. So yes, trying to make sure that I've spent my time since starting on getting the LCP architecture right. So much of that, as people will know, is about making the right connections and building the relationships or re-establishing them. That's both in South and West. Tricky start in West, although we have had 2 development sessions where my perspective would be we have managed to get commitment from partner organisations to attending both of those meetings, even at relatively short notice. So I think that's positive. I think it's fair to say there remains some sort of anxieties about how we move forward with LCPs, how the LCPs indeed work closely together mindful of the relationships both with Plymouth and even from a South perspective as well. So I think there's plenty of work for us to do in terms of development and engagement in that space, and to sort of articulate the benefits of working in a way that sort of West Devon have to date, and the benefits of us coming together and working in that way. But you know, I can't deny there's still plenty more to do in that space, as people will be aware. If I just continue for a second, obviously we can then pick up specifics. So we're working on getting sort of joint sessions in place with exec and delivery groups in both settings, working quite closely, as Andrew said, with engagement leads. So already started that with Jane Harris from a South perspective, and we are just on the verge of having a conversation about who is best placed to help support us from a West perspective. There are a couple of names in the frame from that perspective, but I'll pick that up with the individuals and with Andrew, as he's already referred to. And back to the point that I guess Jane was touching on, plenty of work going on in the space of looking at and having oversight of performance and trying to have those conversations in a different way, such that we are clear about what's the most useful value in terms of the way we spend our time having those conversations, and making sure they're extended to mental health, social care and primary care in a way that frankly we probably haven't done before. So there'll still be a focus on acute trust performance, but we need to make sure that's extended and we're having those conversations and we're escalating the issues through the LCP architecture and through to the system performance group. So as Jane's already said, that work is underway, and making sure that we don't just hamper good conversation and progress in another group by sort of filling it with the receipt of all of the current performance reports that might flow through the system. So there's plenty of work to do in developing that in that space, but that's certainly the ambition, as you've already heard, and making sure, as we would have touched on with Jane yesterday, in terms of making sure we've got the opportunity for clinician to clinician conversations to both be identifying some of those issues and to be able to start to unblock them, again probably in a way that we haven't managed to facilitate before. There are forums in place already. I'm not sure in some of those cases they're doing what we would need them to do moving forward. So again, it's about taking stock of where we are and making sure we've got the right arrangements in place to be able to have those conversations. So that's that from a sort of LCP development phase. In terms of the work plan specifically at the moment, as would have also been referred to, there's quite a lot of focus on the what's being termed the sort of end-to-end improvement plan, so looking at all aspects of flow through the system. We've shared our draft with NHS England in a sort of review meeting last week, got positive feedback about the framework and the context and the content, but as is always the case, plenty more still to do in terms of making sure the ownership and engagement is where it needs to be, and indeed that we're clear about the key deliverables and what the short-term impact is going to that's going to flow from putting those arrangements in place. But again, just to say that work is in place. And as you'd imagine, plenty of work going on in sort of making sure we've got the right connections with programs of work for the things that localities will be responsible for having oversight of and delivering, and making sure we are clear and we've got a clear line of sight as to how that's being taken forward in the locality and local system construct, and making sure we're aware of delivery, and again can update appropriately through the LCP exec group. Specific issues and challenges going on in terms of, as you would have heard earlier on, particularly with Torbay and South Devon from a South perspective in terms of ED, ambulance handovers and attendances. So we're pulling a short task and finish group together to make sure we've got the right flows of information, the right focus of effort. That's both in terms of system and system partners, but also what goes on in terms of inside the walls of the trust. So again, that those conversations are continuing, and people are committed to making sure we address some of those issues. And then obviously, as we'd expect, making sure we are clear about the implications in terms of long-term plan, roadmap and operational plan delivery in the short term, and making sure we've got the team up to full capacity to be able to embrace that which is ahead of us. So that's sort of everything that I've got really in terms of by way of update points I wanted to get across, and I guess opportunity for thoughts, questions, feedback as appropriate. Thank you.
Thank you very much, Derek, and certainly the some of the architecture stuff and that you've got in there is really helpful for us to understand how you're trying to link those elements within each LCP together. Really helpful documents. Thank you very much for presenting those. Judy.
Thank you. Yes, the documents are very clear, and a compliment to Derek. He came into this role later than some of the others, and I think he's really come to grips with what the issues are in South, which is the area that I, as a non-exec, have an overview of. Derek, I asked this question of Tim Golby last week, because last month, because I think this is just an incredibly important issue for us not to lose sight of. I'd like to know how the South and indeed West LCPs are focusing on workforce issues. And I think there's no point having really good service plans if we actually haven't thought about two sides of it. Do we actually have the workforce available to implement these things? What is the nature of the local workforce? Where are the areas of shortage and strength? And then what are our plans for filling any of those gaps? Now, I'm not expecting you to answer that individually, but what is the system in both of those LCPs for dealing with these workforce issues? Who's leading? How is it processed? What's happening?
So I guess there are people linked into. I sort of, if you like, rushed through the update and the sort of links and connections with programs of work. So there are people linked into the system workforce approach. What I would say, though, is I think we need a clearer articulation at LCP level of the workforce challenges in each of the areas of service. So yes, linked to the system-wide program of work, but also for ourselves, and to be clear about where that is being taken forward in the LCP. As at today, I would say there is individually and conversations that take place. I would say there isn't a clear place you would point to, and I would imagine that's going to be the delivery group and the exec group, a clear place you would point to say they are responsible for overseeing, understanding, and making sure we are doing something about some of the workforce challenges that exist. I think there's work going on at the minute to scope that and understand it as linked to the system workforce group. But I couldn't point at somewhere where that is actively being taken forward. But that is on my list of things to do. Obviously, I didn't reel off all of the aspects of the programs of work that I'm taking forward, but that is definitely one of them.
Thank you.
Simon, can I just ask you on that one, because you're linked in with the system work, where are there conversations about how that links in and supports each of the LCPs around workforce?
Yeah, so I was going to put in the chat bar a reply to Judy, because I think it's a really good challenge, and I do recall you asked that last time of Tim. So at the Strategic Commissioning Forum, which all the locality directors are at, they've pulled out 3 themes from the work plans that they've got at a very local level that are actually going across all of our LCPs, and workforce was one of those. I was trying to think through what's the right architecture for LCP workforce delivery, so we're not duplicating system or individual organisations, but we're actually doing that bit that only an LCP could add value to. I think it needs a bit more thought. There are plenty of people from the South locality that are involved in the workforce. So Deborah Kelly, for example, from Torbay and South Devon, who's the chief nurse. Judy Falcao, who's the HRD, is also sitting on the people board, and I chair the South locality, and for in transition and handing over the system workforce to Jane. But I think there are enough, but I don't think the architecture is quite right, Judy. So I think probably that needs some more thought by myself, Jane, and the locality director. So I think it's a good challenge. Like I say, I don't want to duplicate organisation or system, just the bits that LCPs can add value to. So I think, thank you for that.
Thank you, Simon. I've got 3. Let's take the 3 together, and then we'll go to Derek with those. So Simon Kerr first.
Yeah, thank you, Paul. Thank you, Derek. I think you mentioned sort of interclinician conversations as being one of the things that you see yourself developing. Do you think is that going to be a part of the delivery groups that you have, or is that something distinct from it? And if so, I guess the vision might be to have a sort of multidisciplinary clinician conversation. And how do you think you might get the right clinicians that might not necessarily be just GPs or consultants, which is perhaps what it's been rather traditionally? How do you think you might get a multitude of different clinicians involved in having those conversations about those clinical conversations?
Thanks. And Susie?
Thank you very, very much indeed. So I wanted to, I mean, when we see all the different reports, one after another, you get this tremendously strong sense of the differences between all the LCPs, and in terms of their development, it's really interesting. John made a really good point earlier about the importance of co-creation, and I think that's one of the reasons why North Devon looks so different and so well developed and strong, because they have had such a recent history of doing that well. Probably the same goes for Plymouth. Other areas have a way to go on this. But I wondered if there was something that we should do as a system to support this, which is about evaluation. When I had a conversation with the high flow work in North Devon, they made a plea for evaluation. We see some rather good evaluation done, but they wanted to do a bit more. And I think that's something which increasingly all our LCPs are going to need. And I think we need to give some thought to how that's done, a central system for doing that. So we really know what it is that we're learning and what should be spread across other, across other LCPs. That's one important thing. Secondly, and again, it came out of North Devon, that work on long COVID. This is something which I imagine is happening everywhere in the system, building services for long COVID. I think this is an area where peer-to-peer support is going to be incredibly important. And I wondered if we could have a presentation at Governing Body from the clinicians who are developing the long COVID service, but also with a focus on, well, what are we doing to build peer-to-peer support? Because I think this is somewhere where the VCSE could be extremely helpful, and we're going to be in this for the long term, I suspect.
Okay, thank you, Susie. There was a third hand, but it's gone down, so, and I can't remember whose it was, so I'm going to take it as having gone down and not try looking for it any further. So I think there's Simon's challenge on, and have we got an idea of what those inter-clinician conversations, how that might work? And I know, Simon, you and I and a number of the other Governing Body GPs have had a discussion about your roles in that, certainly as clinical leaders within your local areas, and you'll be key for that. But it'd be interesting to hear Derek's view on that. Susie, there's something around that evaluation support. Derek's there, but Simon, it may well be that it reflects back to the commissioning cycle and the training that we're doing around the commissioning cycle, because evaluation is key to that. So whether you want to pick that up. Long COVID is a new service that we've set up, so I guess it's a question of Joe, I suspect, of when's a useful time to try and gain some learning from that and try and understand how that's working both in localities and also that cross-locality support. So Derek, back to you first, I think.
Yeah, okay, thank you for that. So so one of the things I've been doing, which I referred to, is just looking at the current way we bring people together from an LCP and a local system perspective. So I say there are current groups which have clinicians on them and have primary care attendants, etc. But I'm not sure, in terms of the question Simon raised, in terms of will it be through the existing architecture or through the delivery mechanisms. So I think that plus something in addition which brings people together in a different way to which we have previously, and giving that opportunity, I think paying particular attention, because this is the conversation we had with Jane yesterday, where we had a bit of challenge to ourselves about, so how are we doing that, how do we intend to do that, how do we intend to identify issues, etc., and have those conversations so that we can set about resolving some of those issues that we face. So I think we need to put something else in place, to be honest, Simon, that does that and pays particular attention to it not just being the same people we might get enthusiasm and engagement from, and thinking carefully about how we bring a broader a broader range of clinicians together to have that conversation. So that's definitely, I think, where we are. So I'd agree with that as we had the conversation with Jane yesterday. And I would say from a South perspective, so again, there are a range of meetings in place. I think we just need to test the way some of those things are working, test attendance, and whether they're adding the value that we would need them to work in this way. And I'm not sure they are at the moment, to be honest.
Derek, that's really helpful. And can I basically ask, I want to ask our governing body GPs to really work closely with Derek and the other locality directors in shaping and forming that and developing that clinical space within each of the localities, so that all of those benefits that you know and you've highlighted some of them, Simon, that we can realise those. Okay, thank you. Simon Tapley, did you want to bring up about the evaluation element of those services?
Yeah, happy to. And just obviously in the spirit of co-creation, we would want to make sure that clinical input is co-created with all professionals within the locality. Very big believer in not wanting to waste people's time. So getting people along to a meeting, if we're only going to discuss a couple of pathways, is not helpful. But actually having a broad church will be good on our overall strategy. Just in terms of evaluation, Paul, you're absolutely right. It's a key part of the commissioning cycle. We've got a strategic intelligence and clinical effectiveness team who work under Kelvin Grabham, and they would be the expert support for localities to make sure that we can evaluate, share and adopt into other areas. So that's how we would do it. But as you know, my mantra is you cannot evaluate properly unless you set yourself a good baseline and good targets and outcomes in the first place. So we need to make sure we get that bit right too.
Thank you, Simon. And Joe, long COVID.
Yeah, thanks, Paul. So this is a service that we set up so it went live in January. The service that we've got in place, we've got a central point across Devon where clinicians work together to assess and triage patients. But then very much the service is at place level. So those individuals go into kind of existing kind of services and sort of community support that's out there available. So I think there are two things to do. I think one is I will go back and have a conversation with the team and the clinicians about when's the right time to review the pathway. Is that working? What are the and evaluate its effectiveness. And then the second bit probably is something linking to localities around that voluntary sector and peer support. So I think that will probably be something that I think probably is best picked up at a locality level. But I will take that away and happy to report back.
Okay, thanks very much. Thanks very much, Joe. So I haven't got any more hands. Derek, can I just ask you to liaise with Andrew Millward just on your sense of where we are with the West LCP, and just check that green RAG rating reflects the progress that we should be making there, because there is a sense that it is behind the curve compared to a lot of them. And if you could just work with Andrew on that to make sure that you're comfortable that reflects it accurately, that'd be very helpful. Okay. So thank you, Derek. Thank you for your time, and thank you for hanging on because we were overrunning. So thank you for bearing with us. Assurance Committee Chair's report. I'm going to take primary care commissioning and quality as read, and just spend the last few minutes with the Finance and Performance Committee, because there are two specific asks of governing body in that. So Graham, I'll ask you if you can take us through those, please.
Thank you, Paul. I'll try and be as brief as I can. We've spent a lot of time this morning talking about performance, and I guess one of the other sort of legs of the three-legged stool is finance and living within our means. We've had the position over the last year of a temporary financial regime, which has allowed us to break even. What governing body has been asked to do today, and this is on page 3 of my report, there is a recommendation to approve a budget for from April to September 2021, the first 6 months of the year, otherwise known as H1. That budget is spelt out in some detail in Appendix 1, Table 3, and John Dowell will take you through that and answer any questions should you have them.
Thank you, Graham. Should I just pick up on there whilst people are thinking for questions? So the paper that you've had a chance to read, it's worthwhile emphasising a couple of things in public session. So it's here for good governance, for governing body approval, and we will report performance for the first half of the year against the budget as approved. Quite a lot of context in the paper, and this is very much again a system allocation to the Devon system, of which the CCG budget forms part, but you can see in the rest of the paper how we're proposing to deploy the resources across the NHS system. Important to note that the envelope includes funding to meet the long-term plan commitments, in particular for mental health services and for primary care services. We are required to meet those in full, and indeed our plan does meet those commitments in full. The detail that we're asking you to approve today, as Graham has said, is set out in table 3. I would re-emphasise again that the numbers there are for a half year, so the period from April to the end of September. I make some reference in the paper about what happens beyond that point. We will still await further confirmation of the existing allocation and so on, and that will be the subject of further reporting through to Finance Committee and to Governing Body ultimately. But on this occasion, we're just asking for approval for the half-year budget as set out in table 3 on page 140 of the paper. I'm very happy to pick up any questions.
Thanks, John. So any questions for John? Nick.
Thank you, John. When are you likely to hear about the H2 timing, and when will we hear about it, or have you got no idea at this stage?
Not that I have no idea, Nick, but there's no firm date. I mean, the significant thing is national level discussion between NHS and Treasury, which is very much linked to what's the situation and demands on the NHS across the country. So things seem to be moving in the right direction in terms of the pandemic. So I would expect that will be facilitating some sort of outcome from those conversations fairly quickly. We have regular reports in finance community from the National Finance Director, so as soon as we'll know, we'll pass that on, but there is no firm date for that at the moment.
Okay, but thank you.
Okay, so I've got no further questions, so I'm going to do it by exclusion. So I'm going to ask people to raise their hand if they feel unable to support this budget. Then in which case, as a governing body, that is approved. Graham, you had one more ask of the governing body around a development session.
Yes, well, we were offered as a committee a development session by Barbara Jones on the new procurement legislation on which the government has been consulting, the provider selection regime. That felt so important to us as a committee that it really should be offered to the whole governing body. So we're just suggesting that a development session that would involve all of us is set up when opportune.
I can see enough nods for that. So can I ask, because Nick Ball, you're working with Ginny around the development work for the governing body, can I ask you to take that away then and see where we can fit that in the opportunities that we've got in the next few months? That'd be helpful. Okay, thank you all. In which case, that's the end of our public meeting. Thank you all for your time and for your energy and focus. Thank you to members of the public who have joined us.